about lipodystrophy with Dr. Anna Steers, and I'll introduce her afterwards. And then after that, Professor Semple might come back and talk a little bit about autoimmune hypoglycemia as well. So I'll hand over to him now, and he'll share his screen. And I think Prof. Semple, you want some audience participation. So unfortunately, you can't unmute yourselves today, just because we're expecting quite a lot of people on the call. But please write in the chat as well. And any questions, pop in the chat as well. So I'll hand over to you now, Prof. Semple.
Thanks very much, indeed, Mo. So a pleasure to join you all this morning. I know it's borderline microaggression to ask for any audience participation at 8:45 on a Friday morning. So it's very light touch, I can assure you. So yes, so it's, you made it sound much more formal than what I'm going to do this morning. I'm going to take you on a wander through some diagnostic aspects of insulin resistance and the insulin resistances, I might say, with reference to some rare cases which are good to know about, but also illustrative, I think, of more common phenomena before Anna takes you through the lipodystrophies. But first of all, this is I think I can promise my only audience participation slide if I can actually get my slide to advance. So there's a fairly, and I'm taking this from the perspective of a lab sitting looking at some results, and this is really just to sort of warm up and try to work out roughly where you all are in terms of diagnostics. And I can see from some of the names on the call that there's some extremely experienced people and perhaps those who are less so. So faced with simply an insulin immunoassay result alone, which might arrive with a normal range of something like 0 to 60, it may differ from lab to lab. I'm presenting you there with a series of results. These are all in picomoles per liter. Remember, some labs still report in milliunits, which means you need to multiply by 6 to make that conversion. So always be alert to units. And I guess my question is, which of these alone unequivocally identifies severe insulin resistance? What are your thoughts? So where would you be confident, irrespective of any other information, that there is severe insulin resistance? Any quick thoughts? Just give me a number, tell me you can't be sure, whatever you wish. And through some electronic wizardry, either that will be transmitted to me or I might see it popping up on the screen. This is the key test of whether or not you are different to students. And so far, I'm afraid you're stumbling on this test. So where would you say, yeah, whatever anything else is, this is insulin resistance. Can you tell that from this list alone? Okay, so my answer would be, in the absence of external cues, I think you can't be completely confident at all, either that there is definitely insulin resistance here, or that there is no insulin resistance. First of all, that's because of the possibility, of course, of assay interference. And once you go up to the top end of that range, that 80,000 picomoles per liter is about the top end of where you can possibly see insulin resistance in an infant who's got no insulin receptors, for example. But equally, it's a sort of spurious result you might well get if you have interfering antibodies or macroinsulin. And conversely, what about a level of insulin which tells you unequivocally that there is no insulin resistance? Well, of course, you can't tell that either from looking at this list, because even down in the situation where you pick up no insulin, that could be somebody with very severe insulin resistance who is also completely insulin deficient. In other words, somebody with type 1 diabetes, let's say, or somebody post-pancreatectomy who still has severe insulin resistance. Or, of course, it could be that your assay simply isn't picking up the insulin species in the circulation, and this is a person who is awash with insulin. Having said all of that, let's say that these are patients who aren't being insulin treated and patients who don't have any assay interference. Then I would look at this list and say, well, yes, about 2,000 and up, I think unequivocally this is pretty good going insulin resistance. 80,000, 10,000, these move into the realms of very extreme insulin resistance. 2,000 and 5,000, pretty severe insulin resistance, although even down at those levels, I can't yet tell whether this is related to severe obesity or one of the more syndromic conditions that I'm interested in. 800 moves into an insulin resistant sort of state, but again, I need to know context here. So the first context that we might get is glucose, of course, and that's the first problem with using simple biochemistry to detect insulin resistance, because of course we always have to consider what the state of the beta cell is and what the state of the feedback loop is, which connects insulin and glucose so tightly. So 20 picomoles per liter of insulin, comfortably in that normal range. But of course, it's not normal according to the rules of feedback. If the glucose is zero point 0.9, that would just put you over the threshold for looking at insulin-driven hyperglycemia, for example, due to an insulinoma. Equally, if you have a glucose of 27.3, your beta cells are so decompensated, then it's doubtful that actually you're generating a very exuberant insulin response at all. So I'd expect the insulin levels, even in the face of severe insulin resistance, not to be extreme at that level, maybe more of the 2000 sort of level. And it's in the intermediate sort of states, the sort of 5 to 12s, where there is some degree of beta cell decompensation, but the glucose levels are still up and driving insulin secretion, where you do come into the problem of trying to deconvolute hyperglycemia and insulin, and that's where indices such as HOMA are important. So it's all a little bit of a moving feast, and context is everything when trying to understand insulin resistance. So let's say with a bit more contextual clinical information, you are convinced that numerically there is good going insulin resistance. Then I view diagnosis of insulin resistance as being very much more than just insulin and glucose alone. It's part of a more complex syndrome, and those other elements of the syndrome, even just the biochemical syndrome, can be very important in steering you towards one diagnosis or another. In other words, there are insulin resistance endophenotypes, and this is what we're going to talk about today. And just to make the point that lipids really matter, and something as simple as triglyceride and HDL cholesterol will help you to triage insulin resistance into different categories, and I'll show you some of those today. So a resolutely normal lipid profile, in other words, a healthy HDL cholesterol and a low triglyceride in the face of severe insulin resistance pushes me towards an insulin receptor problem very strongly. Whereas the more exuberant the dyslipidemia is, the more I'm thinking in terms of the conditions which Anna will discuss. And then, of course, there's a whole bunch of other stuff which is also informative and useful. C-peptide will come on. It's obviously useful, and you'll notice I've abandoned my audience participation. I read the room and realized that it's too early on a Friday morning. C-peptide is useful for several reasons. First of all, in the old-fashioned sort of
Professor Semple, sorry,
yeah.
there are I don't know if the chat is
Oh, I
okay.
can't see the chat.
Oh, can you not? Sorry, because we were writing things.
I'm unfairly impugning you, am I?
Oh,
That's
sorry, I can read out, but there were quite a few there were quite a
oh
few
good.
lots of numbers put in the chat. So,
Let
um,
me see if I'm just trying to work out how I can see the chat. Oh yeah,
because
there we
you
go.
is
Excellent.
that oh perfect. Okay,
My apologies.
sorry.
So okay, good. So actually, well, well done, everybody. I've been completely talking over you. So yeah, and so I think the things you were saying were very sensible looking back on those numbers. They more or less aligned with what I was thinking. Um, and I guess the only additional elements I was layering on were whether or not the assay is reliable and also that understanding of what the glucose was. So these are sensible thoughts about insulin levels. And then, of course, context is important. Good, excellent. Now we have restored communication. So maybe somebody could tell me why is C-peptide useful in the context of insulin resistance? Why might it add additional information? I mean, apart from anything else, in many centers, it's a real pain getting insulin assays, especially in a busy diabetes or endocrine clinic by the time you have to hunt around for ice and lithium heparin bottles. And so I also sometimes use C-peptide as a sort of cheap and cheerful surrogate, just as a crude screen for insulin resistance. But why else might C-peptide be particularly useful in conjunction with insulin? Anyone have any ideas? But perhaps not. We'll come back to that. So the rest of these markers are all of some use, with the possible exception of leptin, which is a more specialized test available in Cambridge. Leptin more or less will give you an indication whether what the functional fat mass is in the body, and that's pertinent for some treatment decisions, and relevant also to lipodystrophy, but not so relevant to the diagnosis of insulin resistance per se, although it gives you a sort of biochemical impression of adiposity. C-peptide has use again in helping to decide what sort of insulin resistance you're dealing with, and I'll come back to that. Liver function tests, together with lipids, give you clues as to whether there is any fatty liver, any MASL present. And again, that's something which you won't find in receptor problems, but you will find in other types of insulin resistance. SHBG and IGF-BP1 are both, interestingly, they're profoundly suppressed in the face of insulin resistance, unless it's receptor insulin resistance, in which they go up, and we'll come back to those. And testosterone and urate also commonly elevated. But again, we'll come back to those. And then very finally, so let me just refine my cursor. You actually need to know more clinical context as well. And so diagnosing severe insulin resistance is very, very rarely a function of simply looking at a biochemical set of results. And this is where the challenge comes in that gap between lab and clinic or ward, where you really need to look across this whole dashboard to form a reliable view. And often having some knowledge of time course as well is important. Okay, so the first issue, of course, is that while many labs do have a normal range for insulin, it's really not very meaningful without knowing other stuff. Just to look at one dimension of intersectionality, of course, obesity is important. And what you have here is a graph taken from several hundred people in Cambridgeshire without diabetes, where you can see their 50th centile of insulin plotted in the solid line, and the fifth and the 95% confidence intervals on the regression line there as well. So you get the sense that, and this is just fasting insulin, you get the sense that as people become very obese, there is a drift upwards in the fasting plasma insulin. This is sort of population insulin resistance appearing, although there are some people who resist that to a remarkable degree and barely have a rise in their insulin, even in the face of severe obesity. But there is this long skewed tail where you can see that some people do very badly. These are the people that crowd our clinics with the metabolic complications of obesity. And this is probably mostly inherited polygenic tendency towards insulin resistance. The sorts of conditions that I tend to look at, the severe insulin resistance, where there are specific diagnostic tests and specific treatment strategies, tend to occupy these orange and red zones up there. But you'll appreciate from what we said on the last slide that given just an insulin level, I need to position this in the context here of BMI, ideally also with sex, and that's before we even consider ethnicity. So these are not finely parsed, these distinctions. And then, of course, especially if a sample is taken sort of ad hoc in clinic, you need to make a judgment about where it sits in the sort of feeding fasting spectrum as well. Now, I've just taken these from supplement of one of our papers, so you can ignore the whisker plots. What you also have here is the same schema of 50th centile and the extremes taken from the general population, but during the course of a glucose tolerance test. So this is the 95% confidence interval for glucose. And similarly, this is it for insulin as well. So you can see that insulin levels of 600, maybe 700 in this white East Anglian population are indeed somewhat insulin resistant, but they're just up towards the top of the 95% confidence interval of the range. And so I was suggesting to you that once you get into the sort of thousands, 1500s, 2000s and up, that is unequivocal, very severe insulin resistance. And then just to remind you, and this is something that I may come back to if I get a chance to talk again after Anna, of course you need to understand what you're actually trying to assay in the circulation, what's in the circulation. And this was merely some work that was done with the Exeter team by David Church some years ago, where they panned a series of the insulins and insulin analogs available at that time against some of the common assay platforms. And you can see that some of the real workforce assays, in fact, are more or less specific for native human insulin and won't pick up any of the raft of stuff likely to be in the blood of somebody who was insulin treated. So again, you need to bear that in mind as well when interpreting bodies. Okay, so to jump away from the lab to something a little bit more clinical, this is, I always like to show this just as a reminder that we can perhaps be a little bit blasé about insulin deficient diabetes. But remember, until 1922, type 1 diabetes was an emaciating, fatal illness which normally affected people, well, most commonly affected people 12, 13, early puberty. And on diagnosis, it was essentially um, equivalent to being diagnosed with an advanced malignancy. It led to cachexia and death, and really the only treatment was starvation. And yet, within 4 months of administration of insulin, you can see the dramatic change in body composition. So the syndrome of insulin deficiency is a horrible and dramatic one of cachexia, acidosis, hyperglycemia, and death. And just to remind you, it was really Harold Himsworth who mostly formalized in the 1930s the fact that not everybody behaved like that. So indeed, there was a population of people with diabetes who did spectacularly well with insulin. And yet, using his protocol of giving glucose and insulin together, and of course, he had to do those together to stop hyperglycemia, he did this and then he measured the difference in capillary and venous blood glucose. And in those people who have what we now call type 1 diabetes, you can see that giving insulin led to a big difference between capillary and venous blood glucose. In other words, there was a huge amount of glucose being extracted. But there was a subpopulation of people, usually older and a bit more overweight, where you really got only a minor separation between the two. And that's where the whole notion of insulin resistance appears. So I've obviously got some automated timings on my slides. And insulin resistance has been it's been a slow burner compared to diabetes, partly because of the bluntness of the biochemical tools for measuring. You know, immunoassay didn't appear till the late 60s really for insulin to prove hyperinsulinemia. And it's a little, it's got a much less high profile in the minds of clinicians than glucose. So insulin resistance is not the same as diabetes. Many of our patients with very severe insulin resistance don't yet have diabetes. Um, and the complications of insulin resistance, which first present to a doctor, may just as well go to endocrinologists or gynecologists or dermatologists or liver doctors or go to the lipid clinic or indeed to the acute surgical take as pancreatitis rather than to a diabetes clinic. So, although insulin resistance is a term perhaps thought about most in a diabetes clinic, there is a big need for this raft of other specialities to be aware of it as an important entity even before diabetes appeared. But we don't measure insulin very much, and that's where that sort of more gestalt view of a wider clinical syndrome is very important in short circuiting the need to find insulin and send samples off to clinic. And most of it is related to obesity and background tendency. But it is important to watch out for genetic or acquired forms because there are specific treatments. And we really don't have a very, very clear view of the epidemiology. I think it probably is significantly rarer than MODY, certainly the genetic forms, but we really don't have very accurate estimates. And that's partly because even if you have a genetic form of insulin resistance, it really interacts very much with your life stage, particularly puberty and obesity. So it sort of waxes and wanes across your life. One of the nice things about this is that it is not simply a diagnosis that can be made from one blood test. And all this contextual stuff is important, and especially bearing in mind different degrees of decompensation. So a thoughtful clinician is still the key route to diagnosis for people with severe insulin resistance. Now, just to remind you, I often start off my talks with this slide to say that look, we all care very much about obesity, partly because of its mechanical complications, but to a large extent because of its other complications. Its association with diabetes and microvascular disease, its association with progressive liver disease, its association with atherosclerosis, cancer. You would have seen the CRUK adverts. It's the second most common environmental factor driving cancer, and subfertility and reproductive dysfunction. So all these things are linked to obesity, and There are reasonably good bodies of evidence to say that insulin resistance is the key mediator of many or all of these. And we'll come back to that and critique that just a little bit in the light of what I'm going to show you. Acanthosis nigricans, it's a very good sign simply because it saves you a lot of effort even before you found that ice and persuaded somebody to send the right sample off. If you can see acanthosis, which is just a benign hyperkeratotic proliferation of epidermis and some elements of the dermis affecting classically the neck. I'm showing some very severe examples here. It goes along with acrocordons or skin tags. So often if you just see somebody in a diabetes clinic with a low neckline and you can see multiple skin tags in a sort of necklace distribution, you're really halfway towards a diagnosis of insulin resistance already. And when it gets very severe, it can start affecting all sorts of body flexures, but ultimately planar surfaces. It can look very different in different skin tones, as you can see here. And it doesn't precisely correlate with severity of insulin resistance, but it's a very good clinical sign. So I always make a point of looking in people's axillae and sometimes asking them about a history of a dirty neck in childhood. And I think we almost can't emphasize the importance enough of the ovaries in severe insulin resistance. And the large polycystic ovary syndrome literature, to my mind, is a little bit more skewed towards primary hyperandrogenemia as the driver of PCOS. And indeed, there is perfectly good evidence that that does happen. But nevertheless, the epidemiological patterns tell us that PCOS tracks very closely with obesity. An observation in all our patients with primary severe insulin resistance tells us that absolutely the poor old ovary sits there as an innocent bystander and it is hit adversely by compensatory hyperinsulinemia, whether that is congenital or acquired. And very high levels of insulin produce this sort of necklace appearance characteristic of PCOS, of the ovary. It looks the same as PCOS histologically. It can be very severe. It can lead to testosterone levels in the male range. This is just some data taken with colleagues in the NIH from the dual Cambridge and NIH data sets, just demonstrating the sort of testosterone levels that we can see in these big selected populations with severe insulin resistance. I'm sorry, these are in US units, but the normal range is indicated here with, so that's about 2 nanomoles per liter. And you can see that there is a wide range. It's not at all uncommon for people to get up into the 5 to 10 nanomole per liter range. Indeed, I think one of the cases which I'll show later on has a testosterone level which gets up to about 50 nanomoles per liter in a woman. So hypertestosteronemia, hyperandrogenemia of a degree sufficient normally to trigger searches for androgen secreting tumors is not at all uncommon in severe insulin resistance. I just add the caveat that after years of severe insulin resistance, sometimes androgen secreting tumors do arise as well. So I think of it as a sort of hyperplastic soil from which autonomous tumors can appear. This is just demonstrating the nuance that, again, different groups of insulin resistance are a little bit different. And using fasting insulin as a rough surrogate for how severe the insulin resistance is you can see that SHBG falls progressively in most types of insulin resistance, the stuff that we don't understand the cause of, or in lipodystrophy. But in fact, with insulin receptor problems, SHBG goes up the more severe the insulin resistance is. And insulin interacts exquisitely at almost all levels of the growth signaling pathway, from growth hormone through IGF-1 and their receptors. It also acts, as I've said, as a powerful co-gonadotrophin. In other words, it amplifies the effects of gonadotrophins and therefore accelerates the trajectory of puberty. So there are a whole range of altered growth dynamics which you can see in people with very severe insulin resistance. This is just a case report of a family who we subsequently studied, where both a brother and a sister showed really very marked prepubertal acceleration of linear growth. And perhaps a more characteristic pattern is an early pubertal acceleration and then early fusion of epiphyses. And this soft tissue growth carries on in adult life. So pseudoacromegaly, not at all uncommon in severe insulin resistance of multiple etiologies, whether lipodystrophic or otherwise. This is a man who has gamma mutation. He has one of the subtypes of lipodystrophy, which you'll hear about from Anna, and you can appreciate his prognathism, his spade-like hands, macroglossia. And in fact, I would say that some of the most acromegalic looking people I've ever seen have been people with primary lipodystrophy or severe insulin resistance. So acromegaly with negative acromegaly testing, please do think of insulin resistance. I think my last general point is that hypoglycemia is an important part of severe insulin resistance as well, usually post-absorptive. And again, it can be seen in the run-up to beta cell decompensation. So it's often one of the first presenting symptoms. About 10% of people with severe insulin resistance due to receptor problems actually can have debilitating postprandial hypoglycemia, sometimes fasting hypoglycemia, sometimes even congenital hyperinsulinism. Okay, so it's not really something I'm going to major on today, but what I've tried to sort of touch on as I've gone through just that simple clinical description is to observe that insulin deficiency is an emaciating syndrome of starvation in the midst of plenty. And if that's all insulin did, you might imagine that an insulin receptor problem or insulin resistance might ultimately look the same, but actually it doesn't. And a lot of the stuff we see in severe insulin resistance, I mean, some of it does resemble insulin deficiency once the beta cells decompensate. But a lot of the other stuff actually features excess insulin action. So this is soft tissue overgrowth, cancer, enlargement of the ovaries. These are not features of loss of insulin action. These are features of having too much insulin acting on intact growth pathways. And similarly, the very severe dyslipidemia may ultimately look like complete insulin deficiency when the whole adipose load is dumped into the liver. But even before that, it's severe, and that's not a characteristic feature of partial insulin deficiency. So what we call the insulin resistance syndrome is a funny mixture of features of not enough insulin action, compensation, and then bystander effects of too much compensatory insulin. Okay, so what do we know about what actually causes severe insulin resistance? Well, there's a bunch of genes, and then we'll tell you about lipodystrophies. But to cut a long story short, we've known about some of the genes since 1988, when changes in the insulin receptor were discovered. But nearly everything else was discovered this century. This is now quite out of date, but it makes the point that it took next generation sequencing to suddenly open the door on what the genetic causes were of all these things. I'm not really going to go into that in too much detail. But the broad landscape of all the genetic types of severe insulin resistance looks like this, and this is not scaled. So in fact, you might imagine at the start that nearly everything was explained by problems with insulin signaling, insulin receptor, or its downstream signaling molecules. And indeed, there are clusters of patients with those who I'll talk about, who are very important and a very clean form of insulin resistance that help us to understand the syndrome. But by far the biggest group are the patients who've got a problem with their fat tissue development, maintenance, or function, which Anna will talk about. And then there's also a deeply fascinating group of odd and complex syndromes which feature insulin resistance as only part. So really, in this first talk, I'm mostly going to talk about the signal transduction, the pure, clean problems with insulin signaling. And that mostly means problems with the insulin receptor, either either congenital or acquired. And I'll touch just briefly on PI3 kinase, which also features some genetic defects which we discovered with others. So now we move into very rare things. So this is the recessive insulin receptor problems. Again, the epidemiology isn't very clear. There's probably maybe 3 or 4 of these cases in the UK each year. So this is very rare. And the best way to view it is as a spectrum. So those who've got no insulin receptor at all have this syndrome, which we call Donahue syndrome. It used to be called leprechaunism, but that's neither scientifically useful nor particularly kind to my mind. So we prefer Donahue syndrome based on the first clinical description. I'll show you another slide in a minute, but it produces emaciated babies with a mixture of soft tissue overgrowth and linear undergrowth, severe metabolic derangement, and almost by definition, they die in the first year or two of life. people with recessive disease with slightly more function left in their receptors have some similar features again, impaired linear growth, soft tissue overgrowth, slightly less severe metabolic derangement. And these days, I would say the prognosis in this group, often it was said to be sort of death in the second decade of life. I would say it looks a little bit more like cystic fibrosis now in the sense that longevity into 30s and 40s is now increasingly documented. But the commonest type of insulin resistance due to receptor problems is autosomal dominant and therefore is by far the most common. Several hundred patients affected in the country, I would estimate. So again, this is the preserve really of neonatal practice, handful each year. It's really a really horrible but clinically and pathological fascinating syndrome. And you can see once again it makes that case that there is this really strange mixture of severe linear growth retardation, lots of overgrowth features, and very severe metabolic derangement. And the usual cause of death is intercurrent infection with RSV or similar, which simply leads to intractably poor glycemic metabolic control. Although the cardiomyopathy, which is a common feature, is another common reason for demise. And this is the slightly less severe syndrome where you can see here, I think, this characteristic thinness of the limbs, a big belly, which is due to generalized hyperplasia of organs. You can see big ears, a lot of hair, really exuberant acanthosis, really pretty unpleasant in the exidy. And again, that once again is that mixture of some aspects of growth being impaired, some being exceeded. And this is probably the child who may or may not be may or may not be diabetic by this stage. So one of the common bits of terminology you get thrown around is type A insulin resistance. And this was a term which was coined really mostly for the autosomal dominant patients. And it was coined in the 1970s by the team at the NIH. And it was coined to distinguish it from, I'll pick up that question in just a second, thank you. To distinguish it from type B insulin resistance, which is the acquired form. And this description is not unique to this syndrome called type A insulin resistance. This simply is the syndrome of severe insulin resistance in a peri or post-pubertal woman. And you can see that often it's the acceleration of puberty and features of hyperandrogenism which dominate the initial presentation. So primary amenorrhea is a common reason for presentation. Probably about 1/3 present with diabetes, 1/3 present with acanthosis, 1/3 present with hyperandrogenism when we look across the features. So Zoggy's asked, acanthosis, if you just see hyperpigmentation, well, I think that's a judgment call, but I think it probably is. As I say, acanthosis varies. People seem to have different degrees of ability to manifest acanthosis clinically. In some people with very fair skins, it can be very mild. In some people, especially sort of South Asian darker skins, it can be very exuberant. But I think any pigmentation which implies a bit of hyperkeratosis in that distribution, back of the neck, under the arm, skin folds, I think that should trigger thoughts of acanthosis until proven otherwise. And actually, if you read the case literature on insulin resistance, it is hyperpigmentation which is often referred to rather than acanthosis per se. So here's a very classic case report of a young woman who was on the small side at birth, but otherwise was well until about 10 when she developed some shaking and sweating episodes, usually in the evening, settling with food and drink, almost certainly postprandial hypoglycemia. But it was only when she developed coarse androgen-driven hair growth that she sought help. She was Italian, and the traditional referral route there seems to be beautician to dermatologist to endocrinologist. And by that stage, she appeared well, but she had no menstrual bleeds, took no medication. There was a little bit of diabetes in the family. Her puberty was actually very well advanced despite primary amenorrhea, but she did have marked acanthosis and moderate hirsutism. And so she was worked up by endocrinologists, first of all, for things such as congenital adrenal hyperplasia. But you can see her results are really unremarkable in the short Somacthin test. Testosterone indeed was 4.2. And almost as an afterthought, they added on a couple of tests. They added on glucose and insulin. And as you can see, the glucose is actually low. And despite a low glucose, the insulin is 1,000. So this triggered an oral glucose tolerance test. And I think this was the ovary, which I showed earlier. So she had a classical ovarian appearance of polycystic ovary syndrome. But her OGTT showed really quite profound asymptomatic fasting hypoglycemia. She was diabetic by OGTT criteria, and you can see that her fasting insulin, which I might expect, well, in the face of a glucose of 2.6, it probably should be undetectable. But I would expect it to be 10, 20 picomoles per liter, even if that glucose were normal. It was going up to 21,000 picomoles per liter. So this is an absolutely classical presentation of type A insulin resistance. This is quite historical now. This is going back to around the turn of the century. This was before we met her in Cambridge. And you can see that her physicians threw an awful lot of stuff at her to try to keep things under control, both the available insulin sensitizing agents, some acarbose for her hypoglycemia, rosiglitazone, as well as anti-androgenic agents. And you can see that fasting hypoglycemia was quite a persisting pattern for the first few months of follow-up before gradually creeping up, probably as her beta cells decompensated. Um, and you can see that her insulin levels were absolutely extraordinarily elevated nearly all this time. This is fasting plasma insulin, you'll note, between 900 and 3,000. Her father wasn't known to be affected. He was a builder, a very active man, except he did say that he absolutely knew he needed to take a mid-morning snack to the building site because he felt very wobbly and unwell about 11 o'clock in the morning, and he was worried he might fall off the scaffolding. And so when we did a long OGTT, you can see that the most prominent finding was, in fact, that we had to terminate. This is not quite right. We terminated about 10 minutes earlier because his glucose fell to 1.9 and he felt very, very unwell. Although his fasting glucose had been normal, he had this spike, which was very different from the confidence range from the population and late postprandial hypoglycemia. His insulin levels were relatively more unremarkable, but you can see in the face of his big glucose load, he was going up to 5,000. So he had severe insulin resistance as well, but a much more male presentation of it in middle age. And this is an incredibly common pattern. What we find and what the literature finds is that there's a preponderance of women to men of about 4 to 1 in first presentation with severe insulin resistance. But then family screening shows a prevalence of about 50-50 between men and women. So in other words, the index presentation is nearly always in a peripubertal or young adult woman, followed by diagnosis, often in a father who was said to have type 2 diabetes in midlife. I'm not going to dwell on this except to say that really hypoglycemia is a common feature of the early phases of severe insulin resistance. Many case reports attest to this. We've just been analyzing hundreds of case reports, every one we can possibly find, and we find that it is the presenting feature of about 10% of people with receptor problems, and it is a feature at some point in the natural history of about 50% of people with receptor problems. Most commonly postprandial hypoglycemia, but as I said, it can also present as congenital hyperinsulinism with neonatal hypoglycemia. So don't be surprised with that. So this is another rare condition, very rare condition, but a very fascinating and very instructive one. And thanks to Anna for sharing this recent British woman. A lot of the work in this condition has been done in the US, so most of my other cases are American, but this is the case of a young woman from London. And you can see that she had been healthy apart from Raynaud's. She had a miscarriage. And then in 2016, she'd begun to develop weight loss together with secondary amenorrhea, having been well up until that point, with hyperandrogenism and diabetes. And really, this progressed very rapidly and became difficult and intractable with very high insulin requirements and yet still nocturnal hypoglycemia, which meant that in fairly short order, she found her way to Cambridge to the severe insulin resistance service. So there was some family history of diabetes and obesity and PCOS, probably not remarkable, but nevertheless there. You can see that during the daytime, very high delivery of insulin was being required via her pump, together with very high doses of bolus insulin and pioglitazone and metformin, and yet control was very poor. So when she was assessed in Cambridge, she was lean. She had marked hirsutism and acne, minimal subcutaneous fat, more prominent residual fat on her gluteal region than elsewhere, very extensive acanthosis nigricans, and acutely enlarged ovaries. And remember, this is different to those other cases because this is a young woman who had been normal until this problem had developed fairly quickly over the course of 6 to 12 months. And you can see that at the time of testing, her glucose was normal, and yet her insulin was 4,700. Now, I don't exactly know which assay was used here, probably an isoinsulin assay, so it probably picked up a lot of the stuff in her blood, but it's conceivable that it may not even have picked up all the insulin-like immunoreactivity in her blood. C-peptide 775, her average glycemia is high, and this is the remarkable testosterone of 54.2, which I'm sure is about 3 times my own testosterone. And this was in somebody who had been uh, normal. You can see that her leptin is low, as I said before. That simply tells us she doesn't have very much fat, which was known from the clinical observation. And then this other marker, adiponectin, which is a rather more specialized marker, but is incredibly useful in this setting. It's available in Cambridge through the Super-Regional Assay Service. It's a fascinating complex peptide, which looks like complement C1q. It's the most abundant product of fat tissue. And yet, paradoxically, in most people, as fat tissue increases and insulin resistance develops, adiponectin drops low. So in the large majority of cases with insulin resistance, adiponectin goes down. Uniquely in the insulin receptor patients or in the insulin signaling patients, adiponectin conversely goes up. So this counts as a very high adiponectin level indeed. And this, together with this degree of insulin resistance, essentially is diagnostic of the condition that this lady has. Importantly, she also was positive for ANA. And in the case literature, that is a very common feature of this condition because this is autoimmune type B insulin resistance caused by the acute appearance of anti-insulin receptor antibodies. And it can occur in the context of malignancy, but by far more commonly, it occurs in the context of other autoimmunity, um, commonly lupus and the related spectrum. And so this again was defined long before the insulin receptor itself had been cloned and sequenced in the 1970s. Um, it has been described mostly in females, although there's certainly some ascertainment bias, I think, because of the nature of the population that the NIH serves in Washington. And it really is a very unpleasant, severe condition, and left untreated, the historical prognosis was poor, with around 40% mortality, although quite a lot of that was because of the associated fulminant autoimmune disease. And the definitive diagnosis is made, for those who are interested in these things, by a sort of immunoprecipitation experiment, except in this case, it's the patient's plasma, which is used as the source of the antibodies. It's incubated with an artificial preparation containing lots of insulin receptor. It's washed overnight, and then the Western blot is done the next day to see if any receptor has been pulled down by the patient's plasma. And so you can see that our first presentation in 2017, there was a huge amount of insulin. There shouldn't be any of this at all. So she unequivocally had severe insulin resistance. And thankfully, this is a pretty clunky assay that used to run in my lab for many years. Some more commercial assays are being developed now, although they remain of variable quality. So the importance of this, A, is that it's an extraordinary natural experiment of what happens in somebody who does not have insulin resistance and then acutely loses receptor function more or less, and then can be restored afterwards. So it's like a sort of human model of inducible knockout, if you want to think in these scientific terms. And like Graves' disease, like myasthenia, it is a condition which is purely driven by the presence of antibodies which block the insulin receptor. And I don't worry too much about this complex algorithm. But essentially, the colleagues at the NIH have worked out that a sensible combination of immunosuppression designed to deplete antibody works extremely well. There's quite a big case literature. There isn't one regimen which works well, but this is the one which has been most widely reported, which includes a combination of rituximab to take away the B cells with high-dose steroids, a little bit of cyclophosphamide. But a variety of other approaches have been described, up to and including bone marrow transplantation. And the results can be very spectacular. This was the regimen of this particular lady who went from having 1,000 units of insulin per 24 hours to being off insulin within the space of just a few months. And so you can see by 2019, she had enormously regained weight. It's a horrible catabolic condition, type B insulin resistance. She wasn't taking any insulin, and in fact, she went on to have successful pregnancies. Concomitant with that, you can see her antibody disappeared. And you can see that everything else nicely restored, with insulin going from 4,700 to 87, HbA1c normalizing, testosterone normalizing, leptin going up to a normal sort of level for a woman of her age, and adiponectin going back to close to a female range. So this is a rare but informative and exciting diagnosis to make because it can be cured very dramatically. Right, just to take a pause and look, I see there's another question popped in. So clinical implications for the father. It's an interesting question for the genetic receptor patients such as him. Well, in fact, I'll come back to that in just a second, if I may, perhaps after the next couple of slides. This is just showing some other pictures from the NIH group showing the appearance of people either before development of insulin resistance or after restoration. And one of the most characteristic features when you see patient photographs is people usually managing a smile in the non-disease state and looking very miserable. And you can see also, even in the context of much darker skin tones, you can see the acanthosis, which in these very severe cases becomes periorbital, perioral, and can even erupt on planar surfaces as well. And this was another patient from the NIH whose care I was involved in, who started off on 18,000 units per day. They're very determined in titrating insulin at the NIH and went to be insulin free 110 2 years later. And these were our assays showing the disappearance of her antibody. So now, one thing which interests me a lot in the more research side of my lab, but it's also useful diagnostically, is that insulin resistance caused by a problem with the insulin receptor. So this should be the cleanest type of insulin resistance. We know exactly what's causing it. It doesn't actually look like the common insulin resistance that we see in clinic in people usually with obesity. And I think that's telling us something about I see I've used far too much time. Never mind. This is useful. We'll finish off and then we'll see if we have time after Anna for some hypoglycemia vignettes. I'm being too wordy. So I touched first of all on adiponectin, which we use as a research tool, which, as you can see here, and this was from our original paper, you can see that these are the sort of ranges of female controls, male controls, different groups with lipodystrophy or other types of insulin resistance where adiponectin drops low. But it's not only preserved, but actually often frankly increased, sometimes grossly increased in receptoropathy. So that alone tells us that there's something very different about it. More usefully in general practice, though, almost never, I would never say never, but almost never is there metabolic dyslipidemia in people with receptor problems. You can see either patients with antibodies or mutations, and this was just our early paper. This is really panned out beautifully since then. HDL is preserved, triglycerides are never elevated, and that's very, very distinct to lipodystrophy, which you hear about from Anna. So that alone is a very cheap and cheerful triage test, which in fact we're just publishing. And when we look further at the livers of people with receptor problems or lipodystrophy or other types of insulin resistance, you can see again, they essentially don't have any fatty liver at all. I'll just make a very small point in passing that another way that you can discriminate the people with receptor problems from lipodystrophy is a very different profile of insulin and C-peptide. So this is nothing to do with exogenous insulin. This is purely endogenous levels. And because insulin is mostly cleared by the insulin receptor, in the face of a receptor problem, insulin levels go up disproportionately high. And that's where the molar ratio, so you need to have them both in picomoles per liter, comes in. So a normal motor ratio of C-peptides to insulin, if you ever looked at these things, is probably of the order of 10, 15, let's say 6 to 15. Whereas if you have a receptor problem, the insulin level comes up and the motor ratio drops down greatly. So this was a fairly recent study suggesting it's a useful biomarker. And I agree with this in patients who have had both done. And you can see that there are suggested cutoffs of the motor ratio, depending on where they are in the GTT, are between sort of 3 and 5. And in fact, that does work beautifully well. This was a family in which some members had insulin receptor problems and some didn't. And you can see the motor ratios there as well. So even just with an insulin and a C-peptide in the face of uh, no exogenous insulin, that's a very useful test. I'm not really going to talk about this except to say that the only other condition we know about where there is also a proximal receptor problem is a condition called short syndrome, where there's an impairment in PI3 kinase, 2 steps down the insulin signaling pathway, and that has the same profile as the receptor patients. So in other words, preserved adiponectin, um, normal lipid profile, and normal liver fat. So that pattern of severe insulin resistance with no fatty liver and a normal lipid is quite unusual and is one of the things which should trigger consideration of insulin receptoropathy. So that's more or less, I'll come to the questions in a second. So insulin resistance is actually much more complex than we think, based on the arguments I've offered. It's a mixture of features of insulin deficiency and um, effects of compensatory hyperinsulinemia. Thinking beyond just an insulin or glucose level is actually very valuable, and this is what I do all the time, thinking across all the clinical, wider biochemical data as well as insulin. And I think that is something which can often be lost in communication between lab and clinicians. And so you'll see partly why I put down some of those things at the start. Okay, so just to pick up a couple of questions before finishing and then opening it to any other questions. So it's a very interesting question. So the fact that people with insulin receptor problems, they do have severe insulin resistance. They can be treated now with metformin and SGLT2 inhibitors, GLP-1 agents. And once they've got through pubertal insulin resistance, they can often be managed quite well in adult life. The key question is, does that benign lipid profile and lack of liver fat, does that translate into a better long-term progressive? Do they have a completely different profile of cardiovascular risk? And that's where we don't yet have the data. We simply don't have enough patients who are old enough to have enough mortality, but we're looking very hard with colleagues around the world. I like to think that that probably is true, and I haven't seen any evidence that it's not, but we just don't have robust data. So maybe the approach to cardiovascular risk prevention should be different in those patients. For the time being, what is important is managing their dysglycemia, especially hypoglycemic symptoms. So the father of the patient I showed you, again, he should have insulin sensitizers, mindful that even agents that don't normally produce hypoglycemia can exacerbate hypoglycemia. So you need to be a little bit careful in receptoropathy. Um, the usual advice, low GI diets, possibly some acarbose, although nobody likes that's very much. And probably he will do just fine. And then for how long will the patient with type B insulin resistance? Well, that really depends. There isn't one answer, and it depends on the nature of the autoimmunity. Sometimes antibodies can be cleared quite quickly with relatively light touch immunosuppression. Sometimes it needs pretty prolonged and recurrent treatment over a couple of years. So I think there's no simple answer to that. It's like saying how much immunosuppression do you need to give somebody with lupus to put the disease into remission. It varies It varies a lot from patient to patient, I think partly depending on the half-life of their plasma cells and such like. And to be absolutely honest, I think we as endocrinologists start feeling very uncomfortable when we move into the arena of heavy-duty immunosuppression. So usually borrowing expertise from local cancer teams or vasculitis teams or whoever is best placed to administer immunosuppression is the best way to do that. Okay, so I'm horrified to see that I've rambled on for an hour. So I'm very happy to take any questions, but I'll stop my show now and take advice from the chair. So,
Thank you so much, Prof. Temple. That was fantastic. If you don't mind, I have a couple of questions. If anyone else wants to write any other questions in the chat, I can read them out. Or I guess we can go through them. The first thing I was going to ask is you mentioned that the anti-insulin receptor antibodies can come on with malignancy, but more commonly with autoimmune disease. If you had seen someone who perhaps had a history of autoimmune disease, like you mentioned, had Raynaud's syndrome in the past, would how hard would you look for malignancy just based on sort of symptoms alone, or do you think these patients do end up just getting CT, chest, abdomen, pelvis to kind of look for these things, or
I don't think that's the primary concern. I think nearly always these are polyclonal responses in the context of a sort of autoimmune diathesis. But by far the commoner scenario is that there will be mixed connective tissue disease or positive ANA and lupus, in which case I don't think there is a particular need to look any further. I think if there aren't any of those things, it is just worthwhile pondering. So usually these are sort of lymphoreticular malignancies, plasma cell dyscrasias, to use the old terminology.
yeah,
So I think just bear that in mind. So I've just occasionally seen them in the context of things like non-Hodgkin's lymphoma, but I don't think there's any obligate need to start pursuing that unless you've got a high index of suspicion.
it's fine. There's a question that's popped in the chat. So are there any identified genetic mutations that protect from the development of insulin resistance despite severe obesity?
So I'm sure there are, and it's deeply fascinating. The problem is they will not be known in the world of monogenic disease because I guess these people won't appear and demand genetic testing because they are not having any complications of obesity. But I mean, it's a source, it's an area of keen interest and active work in population-based genetics. So in other words, you can see in any big population that there is a tail of people who get up to being very obese without major complications. There's a lot of epidemiological argument about whether that truly is healthy obesity or if it's just a sort of transitory state on the way to unhealthy obesity. Probably is a bit of both. And people do look at that with genome-wide association studies and produce hits, but nothing that is a clear story that I can tell you about. But it's deeply fascinating.
Thanks. And someone's popped in about what the clinical utility of the insulin resistance indices are.
So yeah, I mean, I never use them. I think they're very useful tools in epidemiology, but I think if in order to diagnose somebody with insulin resistance, you're having to use HOMA-IR or quickie, then they probably don't have one of the conditions that I'm talking about. Simply because I'm talking about things that are sufficiently obvious that they jump up and and smack you in the face. So if you compute, I mean, and the HOMA-IR is mostly useful to try to deconvolute the situation where the glucose level has gone up. So you're not quite sure if the insulin level is appropriate for the degree of hyperglycemia. So it is of some use. And if you do that in patients with these conditions, those indices will be very high. But I think if you're using them to parse out a gray case, the chances are it's not quite the territory that you're in.
Perfect. Well, it is 9:45. Should we pass over to Dr. Steers? First of all, I'm not sure sort of how long in terms of timing, if we've got time to come back for the for the hyponatremia, but just to say again that thank you so much for that. That was that was fantastic.
Pleasure.
Um,
I'm just a warm-up act. Look forward to it.
Thank you. Thank you very much, Prof. Semple. Next up is Dr. Anna Steers, and I understand she's a clinical lead for the National Severe Insulin Resistance Service, and she's a consultant in diabetes and endocrinology. So we're very grateful to have her here today to talk about lipodystrophy syndromes, recognition and management. So welcome, Dr. Steers.
Thank you.
Are you happy to share your
I'll give it a
screen?
try. Let's see. Can you see that?
Yes, I can. It's kind of on the it's on the if you go to the display settings at the top left, um,
Display settings. Yeah.
yeah, because we can see the if you click swap presenter view and slideshow,
How's that?
uh, no, that didn't change anything, but
Oh,
actually,
did on my screen.
I
It
did
looks all right. It looks all right to
it,
me.
it does look
I've got
okay,
a
yeah.
normal view. I think Matt's got a special view because
Can
he's
I
got.
just see if I can go forwards and yeah.
Yeah, that works.
Did
That
that
does
work?
work.
It looks fine.
Perfect.
Okay. All right.
Um,
So that you can hear me and everything. Yeah.
yeah, and I'm
Yeah.
going to pause recording
Oh
because
yeah.
you
Because
asked not to because you've got photos of
yeah, I
patients.
haven't got
Okay,
consent for
that's okay.
rec-
Thank you. I'm sure we'd all appreciate it.
I use it to advertise that I'm also talking on this theme at the British Endocrine Society's meeting for those who are going to that. So this could be a trailer for that.
Perfect.
Let me just share. So are you seeing this in the right mode?
Yes. Yeah.
So this is a version of a talk I gave a while ago. So the unmet need I tackle with this, and there's a lot of thematic overlap with what we've talked about already. So this is about the way that diabetologists and endocrinologists approach hypoglycemia. And having dealt with a lot of odd types of hypoglycemia over the years, I've formed the view that we have separate homunculi in our heads. So the endocrinologist confronted with hypoglycemia pursues insulinoma with an almost obsessive zeal. It turns out to me, although at the same time they're pretty good at being mindful of bariatric surgery, but the potential for hypoglycemic agents, abuse, non-islet cell tumor hypoglycemia, adrenal failure, and then some of these other things are sort of vaguely in the background, but it's unhealthily dominated by the insulinoma. And of course, in the diabetes clinic, it's really mostly about imprecise self-management with some of these other things. And again, odd stuff around the edges. And actually, diagnosing hypoglycemia is quite interesting. And I think the general thrust of this type of talk is to try to encourage people to think a little bit more forensically and rationally and to use the biochemistry lab to push them in the right direction. So some of it is just vanishingly rare and fascinating, which I'm not going to talk about. This was just a lovely case that we published years ago of people who had activating mutations in the insulin signaling pathway. So rare that it's not worthwhile talking about just now. The second case I'm also going to skate over, but I will just make the point that this was a lady referred to us in Cambridge from one of our regional hospitals some years ago who'd been pretty well up until middle age when somebody found incidentally that she had hypoglycemia. And more or less her life had then been decimated by excessive engagement with endocrinologists and multiple testing to try to track down a putative insulinoma. As you can see, it looked as if she did have insulin-driven hypoglycemia. She had a low HbA1c. She had, you know, they went at her pretty hard, I think it's fair to say, if you look at this range of investigations. And then she came across to us, and and this was really Ben Challis who did a lot of this work in Cambridge. We did an oral glucose tolerance test, and what struck us about that was that she was low at the start in the fasting state, about this 2.3 level, and then after the glucose excursion, she sort of settled back to about 2 again, and sat there. And peak insulin was a little bit high, but it was relatively unremarkable. And in fact, when we did longer overnight screening, we found that she was more or less sitting on 2.1. So Ben had the great idea that actually maybe this was a set point problem. So one weekend he came in and he personally sequenced the glucokinase gene, the well-known MODY gene. And to cut a long story short, it turned out that she had an activating mutation in glucokinase of the type that's been described. In fact, this mutation had been described in congenital hyperinsulinism. But in her case, this actually hadn't caused her any symptoms until it was picked up incidentally. And then when we went and looked at her family history, found that she had the mutation, as did her. So this is the proband, as did her son, who drove up to see us one morning, and it turned out his random glucose asymptomatically was 1.9 when he got out of the car, rather alarmingly. Her father was being treated medically for a presumed insulinoma. Again, he had the mutation, and other members of her family had really had their lives dominated by the discovery of hypoglycemia and then instrumentation and investigation by endocrinologists. And drugs really didn't do very much simply because she had this robust set point trying to set her glucose at 2.3. And in the end, the most decisive thing we did that was a benefit to her in her life was education and understanding that her set point was 2.3. And actually, she was okay at that level. And so we gradually weaned her off testing, stopped people giving her diazoxide and octreotide and acarbose, and she sort of regained her life and was very happy. The risk was that with this baseline level of 2.3, just a glycemic challenge was enough to tip her. There was no buffer, so she could go into neuroglycopenia quite quickly. So she and the rest of the family required some education. So it's a rare case, but it just makes the point that we also can accidentally do harm by repeatedly doing the same thing, which is proven not to provide a result before. I think was that Einstein's definition of stupidity. I can't remember. That's a little bit strong, but I think we need to think a little bit more widely out of the box if we fail to find an insulinoma, even in the context of insulin-driven hypoglycemia. This is a case I talked about already, just making the case that there is hypoglycemia in severe insulin resistance. That was genetic. This is another case of type B, remarkable only because this was a Malaysian lady who presented primarily with hypoglycemia, with high insulin levels. In Malaysia, she was frisked, had a whole body check, and then was locked in a room for a week to make sure that she wasn't taking insulin. And indeed, this pattern persisted. And to cut a long story short, she had antibodies which we diagnosed, and those were cleared. And so it's quite common in type B insulin resistance to go through a phase where there are enough antibodies around to drive hypoglycemia, and that can predominate. But the one thing which I really want to trail a little bit more are the two entities of anti-insulin antibodies, either in those who don't take any insulin or those who have who are insulin treated. So insulin autoimmune syndrome, Hirata syndrome, quite well recognized. If you read the literature, it says it mostly occurs in the Far East, pretty rare in this country. But I don't think that's true because without trying very hard, David Church and I, simply by giving a few talks, solicited quite quickly quite a large number of cases from the UK, where the classic presenting problem was postprandial hypoglycemia, sometimes very severe, sometimes enough to induce seizures. This was one of our cases who was a lady who presented to A&E with a glucose of 1.7, high levels of insulin, but really it was difficult to reproduce this on conventional challenge. We developed a pretty simple workflow to work this up. Detecting anti-insulin antibodies does not diagnose this condition, but it's a useful screen. And using the assay we have in Cambridge, we found extremely high levels of anti-insulin antibodies. Again, we don't really have time to talk about this very much today, but working with biochemistry labs such as in Guildford or Cambridge or elsewhere, or even a local lab, then asking the question, could there be anti-insulin antibodies which are changing the pharmacodynamics of insulin here? Could they be present is a very useful thing to do. Pretty well akin to looking for macroprolactin, which of course is a routine check in screening for hyperprolactinemia. And so with a little bit of care, PEG precipitation alone is often enough to identify cases where there is a lot of antibody binding insulin, which effectively results in very short-acting insulin or native insulin being turned into an ultra-long-acting insulin, which can blunt the acute effects but can be leached off by reversible falling off the complexes during the night to produce hypoglycemia. And David developed a nice workflow with gel filtration to proved that in cases such as this, A, the immunoassay result was spurious because of antibodies, and B, you could actually measure a very large amount of high molecular weight insulin on gel filtration to prove the concept. And this is an example of a classical profile. So this lady was progressively falling low every night. This is as the bound antibody is releasing insulin. So effectively, she's had a very large overdose of slow-acting insulin. But then the buffering effect of antibody mopping up insulin during the daytime was causing hyperglycemia postprandially. Once again, the approach where it's really convincing and you're sure that the risk-benefit analysis is acceptable is to clear the antibody, usually polyclonal antibody, using the types of approaches we talked about before. And where that works, it can be spectacularly beneficial. I just sound a note of caution because we similarly saw other cases, such as this young woman who again had a very severe presentation, recurrent hypoglycemia of the order of 2, very, very convincing large amounts of macroinsulin. Most of her insulin was bound in these high molecular weight complexes. And she had a whole raft of immunosuppressive treatments ranging from prednisolone to dexamethasone to mycophenolate and azathioprine. And in truth, although this ultimately did some good, she also developed Cushing's syndrome, agitated depression, hip avascular necrosis. And so, and even with the rituximab, this was a torrid clinical course. And the last time I heard from her some years ago, she actually was just about managing things and doing better. But the antibodies were still present. So sometimes these antibodies can be quite pernicious and difficult to clear. And in many other cases, we've seen the mere knowledge of the presence of the antibodies and rational adjustment of treatment has been enough. So we don't yet have any trial evidence to say exactly when it's right to go in and clear antibodies, but it can be very clarifying, at least diagnosing them. And once again, I make the case from this case series we published in JCNM. You can see the patients had a lot of determined investigations to look for insulinomas from endocrinologists along the way. And I'm probably not going to say much more, except that this also sometimes happens in insulin-treated diabetes. Although in insulin-treated diabetes, it's pretty unremarkable having antibodies, so they're a little bit less useful. And I became interested in this in my routine diabetes clinic when I saw a man who'd had type 1 diabetes for 60 years and who all of a sudden had developed several months of intractable morning hypoglycemia, which was putting him at risk of falls and damage, and yet daytime hyperglycemia. So his practice nurse had been reprofiling his insulin in a bizarre way. And my first check with our local assay showed that insulin levels just ad hoc in the morning were undetectable. So I asked them to go back and use their Mercodia assay with a much wider range, and they found 37,000 picomoles per liter at about 10 o'clock in the morning, which is wildly abnormal as well, and I think clearly spurious in this context. And that's where we got going with David Church, with again wondering if we could do something in the more complicated patients who have insulin-treated diabetes, also to find that subset who actually have antibodies which are not just present, but which are high enough affinity and capacity to be mucking up insulin pharmacokinetics. And that's where we developed a very pragmatic approach. First of all, proving the concept with gel filtration, but otherwise suggesting some cheaper and cheerful ways to use PEG precipitation. So I don't really have time to go into all that now. But I think my ultimate conclusion would be that there are a subset of people with very labile diabetes, but especially with patterns of recurrent hypoglycemia, sometimes with stories of being able to come off their insulin without ketoacidosis, where you can demonstrate very large amounts of bound insulin in their blood. And some of these patients have got as far as being worked up for islet cell transplantation before this was found. And some of those patients have done very well when the antibodies have been cleared. It's still a little bit of a gray area, though, and in fact, in some of the pediatric cases, there have been concerns about safeguarding raised because of possible misadministration of insulin to children, when in fact, all that was happening was they effectively had large amounts of bound insulin in their blood at night, which was causing nocturnal hypoglycemia. So I need to be very careful not to create some monster, to create a spurious condition, because the vast majority of patients with labile diabetes or poorly controlled diabetes, it has sort of behavioral origins or self-management origins. And there are also a group of patients in whom we were able to demonstrate small amounts of bound insulin of indeterminate significance. So I always have to be careful when talking to diabetes groups to emphasize that while I think this is undiagnosed and is worthwhile thinking about in tricky cases, I also want to be exquisitely careful not to create a new entity which may be a distraction from real self-management concerns. So this is actually now published in Diabetic Medicine for those who are interested. It's a tricky area, and of course, I hope that mass spec may be well on the way to helping to pull apart some of the trickier analytic issues around insulin immunoassay. And of course, there's wonderful centers around the world. I think I saw Gwen Walk was on the call at the start, who can talk with much more biochemical authority than me about insulin assay. So really, it's just to flag that. I think even in a diabetes clinic, sometimes it's necessary to think more as a sort of analytic endocrinologist and measure stuff. And conversely, in an endocrinology clinic, sometimes it's necessary to look beyond the synaptin test and to look for a secretory neuroendocrine tumor, because there is other interesting stuff around. And I think we have the lab tools around to nicely tease these things out. So that really was the main point I think I wanted to make. And again, there's going to be an absolutely wonderful talk at the British Endocrine Society's meeting on this same subject from me in a couple of weeks' time. So, okay, I'll stop there.
Fantastic. Thanks. Thanks, Prof. Semple. Uh, Just a quick question in the chat if you are okay. I appreciate if people want to, because we've got about 9 minutes until the sort of next lecture starts. If you do need to pop to the loo or something, you can do. But are the antibodies directed to the native insulin or to the administered synthetic insulin? Is one of the questions.
Well, I mean, I think both. So it happens in people who are completely insulin naive, in which it's directed to native insulin, and there are some HLA predispositions described. There is some association with drugs containing sulfhydryl groups as sort of promoting that. So it can happen in people who've never seen exogenous insulin, but of course it's more common in people who have been challenged with exogenous insulin, especially. And this was really sort of done to death in the 80s in the era of animal insulin use. But it hasn't quite been readdressed with the same zeal now that we've got all these slightly adapted analog insulins going around. When you find high levels of anti-insulin antibodies, the first thing that people tend to do is rotate through different analogs and try to find the one which isn't subject to the antibodies. In general, I have to say that's a sensible thing to do, but in general, I haven't seen big successes from that approach. It seems the antibodies tend to hit most things.
Right. And can I ask a quick question? What do you think? So it seems as in it makes a lot of sense that for people who've got anti like Hirata's disease, that the insulin kind of leaks off later when they haven't eaten, and that gives them hypoglycemia. But you said with the anti-insulin receptor antibodies, people also get hypoglycemia. What do you think's actually driving that in the? Is it like a
Yeah,
competitive
that's a
thing
different
or? Yeah.
that's a different issue. So it's been well established for many years, and we're actually working on this as a therapeutic option, that anything that's able to cross-link to insulin receptors can stimulate a bit of receptor activity. So almost any bivalent spontaneous anti-insulin receptor antibody has the ability to induce some insulin signaling and cause hypoglycemia when it's present at a low titer. When the titer increases, what happens instead is you get intense downregulation of the insulin receptor. So that's a little bit more complicated.
Okay. Okay. Interesting. Well, perfect. There's no other questions. So just want to say thank you again for coming and sort of giving two talks in the end as well, to us and being, yeah, absolutely fantastic. So thank you so much.
Pleasure. Thanks, Tim.